My name is Amish Doshi. I am a neuroradiologist at Mount Sinai Health System in New York City, where I'm Chief of Neuroradiology and also Vice Chair of Ambulatory Services. This is our agenda for today. We're going to do some speaker introductions. We have a couple, I have an introduction that I'll be giving, and we'll give you a little introduction on SwiftMR. And then we'll have a couple case studies, and then some research and clinical validation discussion, and then we'll finish up with a question and answer at the end. So just to go through our speakers, the speaker after myself will be Dr. Timothy Deyer, who's Chief Medical Information Officer at East River Medical Imaging in New York City. And then followed by that, we'll have Chris Beaulieu, who's Operations Manager at Naugatuck Valley Radiology Associates. And then the last talk will be by Dr. Kevin Yang, VP of Head of Clinical Research at AIRS Medical. So we're going to talk about AI and its use in accelerating MR and its practical applications. So why accelerate MRI? We know that the imaging market is growing. It's going to grow substantially over the next 10 years. Since there's an increased demand, it's how do we accommodate these patients, right? So there's limited MR capacity. We only have a certain number of MR scanners. So really the only way to do this is really to add more scanners or figure out ways to increase our efficiency. We know that the cost to upgrade or add scanners is significant, but there's also a potential to improve patient experience, right? So if you talk to any patient, they'd rather be in a scanner for less time than more time. There have been challenges with conventional MR. We have longer setup times. In order to maintain good image quality, scan times are generally longer. But there have been advances in imaging acquisition and reconstruction with parallel imaging and compressed sensing. And that's really allowed us to improve scan times over the years. More recently, we're seeing the development of AI and deep learning reconstruction solutions to help improve and accelerate MR. So when we're trying to be efficient, our goals are really to decrease scan time, of course, improve the patient comfort and experience, improve image quality, and potentially actually reduce degradation for things like patient motion, and of course, improve throughput. When we look at image quality, we're looking at a balance between three real things, right? Spatial resolution, signal to noise, and scan time. And these things are always in a balance. Typically when we take one thing away, we're improving the other. It's really hard to get one thing to improve without sacrificing another. So with AI methods, we're actually seeing that this can maybe address a balance of scan time, signal to noise, and resolution, and potentially improve all of these things. There are several products that are currently available that are FDA cleared. And this is a combination, several AI products. And these have several different approaches, or two different approaches, really. One is a DICOM base where it's actually processing the DICOM image. And AI is actually used to process the DICOM image to improve the image quality. The other solution is taking the raw data, using case-based data to actually generate the image. So our goals, of course, are to maintain good diagnostic image quality. So again, improve that signal to noise and spatial resolution with overall decrease in noise, and reduce overall scan time, right? So changing the imaging parameters so that we can actually improve the scan time, but also maintain that signal to noise and spatial resolution. So in summary, use of AI solutions have significant potential to improve MR scan and maintain good image quality. Of course, applications of AI through what we've just discussed can help with throughput and and potentially MRI demand. But it is important to really look at this from a scope of validation, both clinically and through research, when we're looking at these AI solutions. So I'm just going to briefly talk about the SwiftMR product. This is a vendor-neutral MRI reconstruction solution. It's a deep learning-based MRI reconstruction software from AIRS Medical. It can reduce scan times up to 50% and can improve image quality with superior resolution and a denoising algorithm. It's a DICOM-based framework, as I mentioned before. Solutions can either be DICOM-based or case-based. This is a DICOM-based framework, and it incorporates into image acquisition parameters, so modifying the imaging parameters and performing reconstruction on the DICOM images. Here's an example of a standard scan versus an accelerated scan. It's a two-steps process. The scan is accelerated by optimizing parameters, which will result in a noisier image, the image that you see in the middle here. The accelerated scan is then processed with the SwiftMR algorithm to remove the noise and improve the resolution. And you can see that the scan time reduces from 30 minutes to 15 minutes. So it's obviously a significant improvement in scan time. So the product can actually, the SwiftMR product can be used for all body parts and sequences for patients of all ages, including pediatric patients. It's a vendor neutral and compatible with any scanner, regardless of the manufacturer, model, or age. As far as adoption, we have two current SwiftMR users with us today, Dr. Timothy Deyer from East River Medical Imaging and Chris Beaulieu from Naugatuck Valley Radiology Associates. So I'd like to first introduce Dr. Deyer, who'll be speaking about his experience in evaluating AI solutions and adopting SwiftMR.
Thank you all for coming. As Amish said, I'm Tim Deyer. I'm a radiologist and the Chief Medical Information Officer at East River Medical Imaging, a private practice in New York. So I just want to start by talking a little bit about our practice, so it'll give you an idea of what we expect out of our MRI scanners and any AI solutions that are implemented. We have 4 locations, 3 of which are located in Manhattan and another location in Westchester County, which is just north of New York City. We are in close proximity to a number of world-renowned tertiary care practices. So our Manhattan offices are at a confluence of Memorial Sloan Kettering, Hospital for Special Surgery, and New York Presbyterian Hospital. So we have to provide imaging that is as good or better than those large tertiary care hospitals. So in general, with our MRI scanning, we're facing 3 challenges that we wanted to fix with an AI acceleration program. First, like anybody, patient discomfort, right? Patients are claustrophobic. They don't like being in the MRI machine. Sometimes they're coming in with pain, which makes laying in the MRI machine very difficult. So we want to address those things. New York City was hit very hard early in COVID. We had a lot of radiology technologists who said, I'm out of here, I'm going to Florida. Concurrent with that, we closed down a number of schools in New York City. So we had slow throughput in terms of bringing in new techs. So we faced a big challenge in our practice in terms of just having enough technicians to do the scanning that we needed to do. And those ones who stuck around were getting very burned out because they were doing additional work to cover for those who had left. And then finally, missed revenue opportunities. You look at inflation over the past 4 years, 20% or so, and it's no surprise to probably anyone here that insurance companies haven't offered to give us an increase in our reimbursements. So how do we deal with that, especially in the face of having to spend more money to get techs to come in? Really, the only way to do that is to be more efficient with what we're using. So we've actually had the opportunity to try a number of different AI solutions in terms of acceleration at the practice. We do actually currently use on some of our machines a case-based AI acceleration, but it's only applicable to our very newest machines. So it's not widely applicable. It works fine, but we just can't use it on everything. We had previously tried a DICOM solution from another vendor. It did improve time, but it didn't improve time significantly enough for us to really change the way that we were scheduling patients. And I was also surprised to learn after we had been using it for a year, our head tech said that operationally it was very difficult. So they would send out studies to the server to be processed, and they wouldn't come back quickly enough. So the tech could actually look at the results and decide if this was something that needed to be repeated or not. So I'm just going to go through each of those three things that we were looking at and tell you about our experience. First, I'm going to start with patient perspective. So this is from an interview that I had with a patient at East River, 62-year-old gentleman. I think he's run a marathon every year for the last 32 years, so really high caliber athlete. But he's had a ton of back pain from kind of beating up his body running these marathons for so long. So he comes in very often for MRIs of the lumbar spine. He's unfortunately incredibly claustrophobic. And just talking to him, he's actually a good friend of mine. He would sometimes avoid coming in for the MRI because he just couldn't bear being in the machine for 30 minutes. So I said, come on in, we've got this new technology. It's gonna take 10 minutes, you'll be in and out. And he was totally blown away. I mean, for him to come in and sit in the machine for 10 minutes was something that was doable. Being in the machine for 20 or 30 minutes, he tried to avoid it as much as he can. So I was really impressed with how much it changed his outlook in terms of getting the MR. Our technologists have really been positively affected by using SwiftMR as well. We have been able to move, because of decreased scan time, from a 30-minute time slot down to a 20-minute time slot, and even with the 20-minute time slot, we're giving the techs a little bit of a buffer there, so if they have a difficult patient who comes in and they need to repeat some sequences, they know they're going to have enough time to be able to move on. Or if they've got a patient that goes very well and things are successful, they've got a little bit of downtime to make sure they can catch a breather, grab a drink, go to the bathroom. So I've heard almost universally from the technicians in the practice that they're just a lot more happy with the way we've been running things lately, because the schedule is a lot more easy on them with the MRI acceleration. And interestingly, as radiologists, we're a little removed from the tech sometimes, but talking to the lead tech, he says because the patients are more happy, the techs are more happy, because they don't have patients that are giving them a hard time. The techs are having a lot easier time with their job. This is just to give you a kind of rough overview of our results in our practice. The far left column there is the scan type. The next column over is what we were originally doing without any AI acceleration. Next column over, the time with the MRI acceleration, and then the final column, you'll see the scan time reduction. So we're averaging probably anywhere, probably around 30 or 40% for our MSK and neuro cases. And you can see this is scan time, of course. This is not getting the patient in and out of the room, but we're well below that 20 minutes in the after Swift MRI column. So we're really having no problem switching from a 30-minute time slot to a 20-minute time slot with the savings we get here with scanning. So with that in mind, just to talk a little bit more about workflow, I've already touched on it pretty extensively already, but it was really important to me in terms of managing the business to go from a 30-minute time slot to a 20-minute time slot. It was the only lever that I could pull to try and get our finances back in balance, because we've had to give raises to a lot of the techs, fairly sizable raises, to keep pace with inflation. And as I said, we're just not getting increased reimbursements from the payers. So this really allowed us to rebalance those things, make us a lot more efficient, and basically increase the number of scans that we could do by 50%, right? So we're going from 30-minute time slots to 20-minute time slots. And even with that, we have enough reduction that we can really get the patients in and out. It's very, very effective. We've totally reduced any backlog that we have. With the shortage of techs, we run pretty close to getting people in within a few days of them calling. But earlier in COVID, we were running a week. Now we're down to just a couple days. We're also very heavily reliant on add-ons. So freeing up some space there with the schedule allowed us to open up some spaces to pull in emergent or urgent patients who needed to be scanned, which helps as well. Just going to go over a couple examples because the question I always get from radiologists when I'm talking about this, whether it be in situations like this or even in my own practice, is how can we be sure we're not missing something, right? AI is scary. You don't know, is something being covered up? Are we missing something? We were very rigorous when we implemented this of scanning patients both with an original scan, how we would normally do it, and then doing a whole nother sequence with AI acceleration because we wanted to prove to ourselves that we weren't missing anything. So up here is an example of an MRI of the knee. On the left is our standard scan without any acceleration, and on the right is our accelerated scan. Do they look a little different? Sure, there's a little bit of difference in the sharpness of the two images, but the pathology, to me, is exactly the same, right? In both of these studies, we've got pretty well seen chondral defect over the central trochlea here. This is on our conventional scan, and I think you can see the exact same thing there. I'm a musculoskeletal radiologist. There's no doubt that I would see the exact same thing on both of these scans. But the most important thing is the quality is the same, but look at the scan time. This took 3 minutes. This is a minute. So we got a huge time savings with no, in my opinion, loss of quality between the two. Here's a lumbar spine, pretty messed up lumbar spine. Same thing here. On the left is our original study before we did any AI acceleration, and then to prove to ourselves that we're seeing all the same stuff, we did the lumbar spine with acceleration. Not as big of a time savings here. We lopped off about 30 seconds. But as you can imagine, this patient is probably in a lot of pain, pretty uncomfortable to be in the MRI machine, so I'm sure they're pretty happy to be in there for 30 seconds less time. And again, looking at the two images, I see everything the same. I can see the nerve roots. I can see the nerve roots coming out of the neural foramen in there. To me, it looks like there's no difference in quality. Actually, a couple months ago, ran an experiment to try and see what we could do with a fairly old open MRI machine. It's an incredibly slow machine, which is kind of ironic that the most claustrophobic patients are willing to be in the open machine for an hour and a half to get their study done. But regardless, we do have a number of patients who like to go in the open. My motivation in putting SwiftMR on this was twofold. A, to see if we could get the time down so these patients who are claustrophobic would be in the machine less, but also to really see if we could get a little improvement in quality. So this was one where we really focused on decreasing scan time, so from 4 minutes down to a minute, a little over a minute and a half. And again, to me, the quality looks identical. On the next slide, I just want to give you an idea. If we did some acceleration to speed things up, what we would get out of the machine without any AI processing. So on the left, this is just a scan that was done in 3 minutes. This would be a hip. We would probably normally scan it at 4 or 5 minutes just to get a little bit better signal-to-noise ratio. But you can see what the processing is doing on the right side. So we're going from this to this. Can I see that there's chondral wear over the femoral head and acetabulum in this really noisy study? Yeah, probably, but it looks a whole lot better here. I can get a whole lot better picture of what's going on in the hip there. So even on an old open MRI, the AI acceleration can be very helpful. I love this quote by Mike. So this is our lead tech. I swear, Swift did not pay him to say this. This was off the cuff. If you have a chance to implement SwiftMR, I don't see any reason why you wouldn't. And I think it's a fair assessment. Our techs like it, our patients like it. I really can't remember any complaints from the radiologists. They don't even know that it's being done most of the time. And it's really ended up with a pretty impressive operational improvement. As you can see up here, we're averaging about 50% increase in our daily scan volume per machine. And like I said, everybody is just very happy using it. So, thank you very much.
Thanks, Tim. Thanks for the overview. The clinical and operational experience that you've had is very helpful. Next speaker is Chris Beaulieu, who's going to expand on that operational discussion and use of SwiftMR.
Thank you. And thank you, everybody, for coming. My name is Chris Beaulieu, and I I come from the side of the practice where I'm a registered technologist from X-ray and nuclear medicine by trade, and then I've converted since to becoming a manager, an operations manager in a full-service imaging center. I've had the pleasure and joy of creating 2 imaging centers from the ground up. So operationally, I've been involved with implementation and various modalities. So I'm talking about X-ray, mammography, nuclear medicine, citing these modalities in our fleet of imaging centers is kind of where I come in my experience with Swift. So that's what I'll shed some light on. Our practice is again, Naugatuck Valley Radiology, and we're out of Connecticut. We're basically along the 84 corridor in the central part of the region. We have 4 centers. We operate 3 magnets, 2 of which like I said, I've been able to start from the ground up. So when I get introduced to a vendor or a new technology, you know, when you talk about introduction and siting, MR is always the biggest lift. It's always operationally the most challenging because of all of the parameters and all of the legality, especially in Connecticut where you need certificate of need, things of that nature. So to make a simple decision in MR is not always the case. But with Swift and getting introduced to them, we were able to see that in reality. So again, 2 of our centers are in a suburban area, 1 is in a busy inner city location. The other thing that this slide points out, and which we'll talk about more and which has already been discussed, is that at each of those centers, we decided on different vendors for each location for MR. As was alluded to, we have a 1.2 Tesla magnet, an open configuration. We have a 1.5, and that's a Fuji, or it used to be a Hitachi scanner. We have a 1.5, which was a Toshiba, now a Canon scanner. And then we have the traditional GE 1.5, and that's at our busy center. So some of the concerns or challenges that we faced is patient comfort, which was, again, talked about. But as an outpatient imaging center serving, you know, a really small community with the 3 centers, patient care and patient repeatability is huge. It's something that we really strive. Patient satisfaction is something we take very seriously. We screen all of our patients after with a post-interview call. So feedback is very dynamically given to us, and we act on it. We have a lot of seniors in one of our suburban locations. It's actually in Southbury. It's the densest population of retired aged individuals in the state of Connecticut, is right where my center sits. So, you know, 45% of them are Medicare driven. So we see a lot of those patients. As you can make the connection, that elderly patient, that long scan time, that claustrophobia, that needs to be addressed or dealt with every day. As you see with extended scan times, it poses that challenge. Backlogs, long waits, as was talked about again, just to reiterate, technologist burnout, and obviously at the end of the day, because we're still fee for service, that missed revenue opportunity. So our radiology group is part of a national coalition that's building called Strategic Radiology. You may see them here. We were fortunate enough to be on one of our forums. We have a very good community of administrators and radiologists across the country, and we frequently get introduced to different vendors, and they were highlighted at one of our events, one of our calls, on our Zoom calls. And I literally got an email with the contact information, and my experience was, as I said, with all these other vendors, it's very difficult to get contact people, very challenging to, you know, actually get to the core of the issue and begin negotiations and implementation. I literally sent an email. We set up a call for the following week. And the first thing that was the most optimistic was that we were able to not decide or have a solution that would transfer across all of our fleets. Because I've come to RSNA for many years, and every time I come, the promise is, you can do a brain in 5 minutes, but you have to buy our GE scanner. You could do a brain in 8 minutes, but you have to buy our Fuji scanner. And you have to get the new upgrade. We were looking for a much more cost-effective opportunity that would solve our network's needs to have that solution across all 3 locations without a heavy lift of implementation and structural changes. And at the same time, being able to service all 3 of the locations, how will we be able to optimize the service time to make those patients more comfortable, but still obtain that image resolution and quality, which was shown on those previous slides. Even to the non-radiologists, such as myself, it's pretty evident. So some of the things that we've seen, these are anecdotal opportunities that we've experienced, much like the slides you saw before. In our practice, we've seen 90% of our image across all 3 vendors, because you do have to, honestly, you do have to dial in each modality or each vendor to the software. So there is there's about I'd say a day of interplay between the vendor, the radiologist, between Swift engineers, the radiologists, and the techs to really get it off the ground. Only a day to really start seeing the benefit of those dramatically reduced scan times. So based across all of our fleet, each one of them were able to shave off 15 minutes. So in an outpatient center such as ours, we're open from 8 a.m. till 9 p.m., shaving off 15 minutes, you're freeing up at least 7 slots or more, depending on, your case mix. As I said before, that less than 24 hours segment of this slide, what that refers to is once we decided on that initial call that we saw enough that we wanted to have a demo, they were able to send us a IT worksheet that was filled out pretty simply by our IT director. We forwarded that back. Then I myself got on the scanners and I downloaded several anonymous scans. Within, say, an hour or so, it took me, I downloaded, say, 4 or 5 from each vendor. So I did the Toshiba, I did the Canon, I did the GE and the Fuji. Loaded those into a secure web portal. And within several days, I was given a very detailed description of, here's your scans, this is the time frame, here's your scan with our proposed reduction. Not only the detailed time analysis of each sequence that we are running on our protocols, but also the image quality. So not only was I able to show immediately the benefits we didn't even demo it yet, it was just giving them some of our scan examples. I was able to show the dollar amount immediately, like what is the increase in possible change for the dollar amount of how many more procedures we could do, what is the increased value to the radiologist and their visual experience with this, and then couple that in with the tech's ability to kind of manage that increased scan time or that increased patient volume. So I would say, in a typical operations with those scanning hours, Monday through Friday, we would do pretty much 16 to 18 would be our sweet spot for a day in scans. And on a good day, we'd do about 22. We'd say, hey, we had a really good day in MR. The techs would feel it. The bottom line would feel it. The radiologist would feel it, reading the scans. And now, 24 is really our low end. And at one point, we did 32 scans in one day, right within that same. And we didn't change staffing, and we didn't change any hours of operation. And our patient backlog has improved. And it says 0. I mean, I will tell you in Connecticut, and I know as we've talked about with the statistics of MR and volume and utilization, we've seen dramatic growth. I talked to our local hospital, which our radiologists serve, at one of our, I would say it's our partner, but our competitor, because we're the outpatient arm. They do a lot of inpatients, but they also see a significant outpatient market to the same refers that we share. So in a sense, we're competing for that same patient. Their backlog is 4 weeks. Our backlog is, when I say backlog, our next available typically is about 6 days. But if you need someone to be done right away, based on our experience with Swift, and as we talk about, and as you just develop your plan on how to make yourselves more efficient, how to find that balance between, I want to maximize opportunity for reimbursement and patient volume, but I also don't want to burn out my techs. I don't want to put them in a position where they're overworked, because now we're almost doubling sometimes their current volume. We were doing 16 on a low end, now we're doing 32. At the same time with the same people, it can seem as if it's going to be a stressful opportunity, but it isn't. So again, just a summary. This shows some of the reduced, these are hours. Mostly everything's about 50%. And as you see after Swift, 10 minutes, 6 minutes, 10 minutes, 11 minutes. We've been able to optimize to a pretty significant degree. So we've only brought 2 of our scans to the 15-minute mark. I think it's brain, they're not even listed up there. I think it's brain and maybe the cervical is there. But most of them are still at 30 minutes. So when you talk about doing more, taking that 45-minute scan for us down to 30, while it's an increased volume for your techs, they find in our workflow, they found strongly, because that's the resistance, right? It's like, how do you sell this as a manager, from my perspective, to your team, that you're trying to rah-rah when there's shortages, when there's challenges to go work somewhere else for $5, $6, $10 more an hour. And now I'm asking you to do more. But what we found after we've implemented it is it really gives them that space to catch up. It gives them that space to frequently throughout the day now, whereas before we were always behind. We were always, and I don't know, but some of the people in this auditorium, they probably are saying, we're always behind. Staff, we're always waiting. Patients are always complaining about trying to get in, or patients will leave because they expect, if it's 12 o'clock, they want to be done at 12 o'clock. Not understanding that every person is an individual, and every scan and every experience in the MRI is different because of those claustrophobic interactions, because of their limited mobility. Well, Swift kind of eliminates all of that. And you could balance that based on, even though we could go to 15 minutes on all of these, if we leave them at 30, well, now we have that factor of opportunity. When we get that first call from those orthopedic physicians that rely on us more regularly than a four-week wait for the hospital, send them right down. Then we just fit them in. Send them down. We'll have them register and tell them they may have to wait 20 minutes to a half an hour. That's a miracle answer to them. So again, stakeholders benefited. I talked about the bottom line, so obviously that's the owners. Patient satisfaction, the most primary stakeholder in this whole exchange is the patient, and that does translate. Translates to repeat business, translates to word of mouth, translates to comfort. And that's really the trifecta that's listed up there as far as we're concerned. And it's funny, you mentioned your friend that comes for the runner. So I had a tennis player, he came to us for elbow MRI. And he's come to us on his right elbow for 2 scans previous to surgery, then had surgery. And in the meantime, thankfully and kind of perfectly, after Swift was implemented, and in elbow, you have to kind of put them in a weird position, very uncomfortable at times. And he was able to come out of the scanner. I actually waited in the room while he was being scanned. And he's like, his words without unsolicited, wait a minute, did you get everything? Because I remember being in there a ton longer. like, what's going on? He's like, is it quicker because I had surgery? No. We actually did 2 more sequences than we did last time, post-surge, so, but you were done in quicker time. So, real-life information from a real-life user. Again, we talked about post-processing. In our practice, because we have a legacy PACS, and we have very, how should I say it, specific radiologists who I want this scan, but this radiologist wants this scan, and I want, when you do this sequence, or when you do this protocol, I want this, you have to add this flare, or whatever. So, because now we can encompass all of that in, and a lot of the post-processing has to be done on our technologist side. It's not left for the radiologist. We provide our radiologists with a pristine end result. They don't have to click, they don't have to window and level, they don't have to zoom. We mag a lot of things, we annotate a lot of different things. So to reach that specificity, our techs are doing a lot more than, say, a typical hospital that just kind of runs the DICOM in and, you know, gets read off-site. So we tend to take that extra time for our radiologists. And our techs are finding that, again, they're caught up with a busier schedule and waiting for the patient to come into the building. And we ask our patients, all of them, to come in 15 minutes early. So again, 0 disruption to patient flow. When we talk about integration, it's a box about as big as this piece here is our DICOM box, which is our gateway. We pre-programmed it ahead of time with all the parameters that we sent them in the pre-analysis workup with our IT. The night of the installation, I think they were supposed to come at 6. He showed up at 4. I was supposed to give them 2 hours of downtime to kind of work with the tech without the patients involved. I forgot to put that in the schedule, so we actually had a full run of scheduled patients for the implementation of Swift. And I will tell you, as an operations manager, which is why I alluded to it in the beginning, there's always a heavy lift. There's always something to be considered. And in this case, I said, hey, you just got to do it on the fly. And they said, no problem. And they actually did it on the fly with 0 disruption, worked around the tech, installed it, and did the tweaks and the implementation. So that was on, say, a Thursday night. When Friday I came in, I just walked in casually to the department, and I said, hey, so how's the implementation going? Have you found it to be challenging? Did it connect? Did everything work? And the answer was, we're already using it. So literally it was overnight that we actually were able to implement Swift without issue at all 3 of our locations. That's just my personal experience. We have 2 other managers that experienced the same situation at our other locations. The customer team and the engineers are top-notch, very attentive, and very accessible. So as I said, there's about a day where you do some interplay to integrate, but then every day since, you know, for the first few weeks, you're tweaking, you're making things better, you're titrating them, those scan times down, and one of my techs that's my lead happens to be my evening tech, so there's a lot of time at night where he's sending emails to our engineers and they're responding, you know, 9:30 in the evening and making changes on the fly. So again, just a quick, I won't bore you with these, but important to see that we at our location have seen those same image quality improvements, and the time, the highlight is the time decrease, 19 minutes to 11 for one sequence. These are our images, 17 to 9. So the overall recommendations, we've seen a minimum of 35% increased daily scan volume, total increased improved patient satisfaction. We maintained and sometimes increased our image quality for some of the RADs perspective. And at the end of the day, why wouldn't you decide to take your best payer and increase those volumes without having to purchase a new scanner? Thank you.
Thanks, Chris. Thanks for that operational perspective. Our next speaker is Dr. Kevin Yang. He's going to be speaking to us on clinical validation and real-world value using SwiftMR.
All right, thank you for the introduction, Dr. Doshi. Hi, everyone. So I'm Kevin Yang, the head of clinical research at AIRS Medical. I'll be talking briefly on our continued clinical validation efforts and also expand a little bit upon what our previous speakers mentioned regarding the real world value of SwiftMR. So to kind of first, to put things into perspective, as you know, there are quite a lot of AI-based or deep learning-based products or technologies out there focusing on different, various aspects of the radiology workflow. So from scheduling, scanning, reconstruction, reporting, or following up on, treatment responses and whatnot. So new technologies are coming out every day to make the lives a little bit easier. But I wanted to highlight this particular paper that came out a few weeks ago or months ago, that not all products available in the market are actually necessarily clinically validated. So why does that matter so much for us? Well, if we come back to this nice illustration that we saw before, if we consider image acquisition and reconstruction, or image formation that is, as sort of the upstream in the radiology workflow, it only makes sense that technology impacting this aspect, such as our product SwiftMR, be thoroughly validated, since the outcome of the imaging will impact the rest of the process and ultimately the patient outcome. So if we look at this from another perspective, so with all these new technologies out there, how can its value be defined in a practical manner? So if we look at different stakeholders, as some of our previous speakers had mentioned, we hear examples like value, such as the ones listed shown here. But how can a product, a service, guarantee that the return on investment or ROI is there to justify the cost of adoption? So this is also a topic of discussion in the related media, in the papers, depending on, of course, the problem which the technology is trying to solve. The ROI might be identified much down the road, or it might be immediate, as this particular article suggests. While there are other algorithms like SwiftMR, which will bring much more practical return on investment, even considering the whole reimbursement situation. So in this talk, I'll be highlighting two key points. One, how does SwiftMR guarantee that the technology works? And how can it be trusted clinically? And also, how can SwiftMR ensure practical return on investment? So first, I will share a bit about our clinical validation processes kind of going on in the background. So since the market launch, and even long before that, we have been heavily invested in validating that SwiftMR works in a real-world environment. So as mentioned before, since we're dealing with the image acquisition and hence the reconstruction side, we had to work in a myriad of different clinical MR imaging scenarios. So this is why we are, as you see on the screen here, we're working with so many different radiology subspecialties from different institutions, different countries, to study and publish SwiftMR's effect on different imaging body parts, imaging indications, diseases, and etc. So while there are a lot to talk about, I'll be just highlighting just a few selected papers from the list. So first one, this is one of our actually newest publications, just about to come out actually. So with routine imaging, brain imaging taking up a high volume of clinical MR, it was important to show that SwiftMR works in such environment. So in this particular paper, we were able to show that the scan times could be cut down in a big tertiary hospital, university hospital setting by up to 40% across the mixed fleet of MR scanners. This was a mix of GE, Siemens, and Philips, I think. And then while, of course, improving kind of quantitative and also qualitative image qualities and also preserving the diagnostic qualities. So this is a sample case. So all the images that you'll see are directly from the papers. And this is a representative case from that particular paper. So T2 flare, the lesion conspicuity of the perivascular vessels or spaces, is a lot more conspicuous with SwiftMR. Same case, T2, more clearly defined large perivascular spaces also can be seen in the comparison with the conventional image that you see on the left side. And another finding from this paper, which was very interesting, was that we also tried utilizing the brain volumetry softwares in conjunction with SwiftMR. So in this paper, we had a 3D T1 image acquisition along with the 2Ds as well. And then we applied SwiftMR to reconstruct those 3D images. And this is the results that you see from one of the brain volumetry softwares. And this is a white matter hyperintensity segmentation in this case. And the paper highlighted that the segmentation results are a lot more clearly aligning with the actual clinical or the image findings. So if we look at another example where SwiftMR focused on improving the existing image quality from your existing protocols rather than trying to accelerate them. So in this paper, we utilized SwiftMR to improve the quality of dynamic contrast in MR images for patients with diffuse glioma. And we are able to show that SwiftMR processed or enhanced images could increase the diagnostic performances, and also along with more consistent arterial input or AIF measurements. So again, some of the selected images from the same paper. Here's this is an example. And so basically, this is a 3D image. And what's unique about SwiftMR is that our super resolution algorithm actually works not only in the in-plane direction, but also the through-plane direction. So when you do your MPRs or multiplanar reconstructions, the results will be a lot more clear and also with improved image qualities, of course. So this is a baseline study, and then this is after the contrast agent arrival, and you can see significant improvements in the detailed tumor features and also surrounding vascular structures as well. And again, the quantitative analysis from the DCE images, and again, the SwiftMR process images provide much more clear visualization of complex structures via, again, resolution enhancement and also noise reduction. And again, so as I mentioned before, with increasing interest in brain volumetry, we also conducted a study focusing on SwiftMR's effect on brain volumetry softwares too. So we were able to, by this study, we were able to show that the volumetric analysis results from SwiftMR processed images were in good agreement with the standard of care. So this is a sample case from the study. So you see, on the left side, you see the SOC, the standard of care image. In the center, you see an accelerated scan. And then we see on the right side, you see SwiftMR processed accelerated image. And you can see that there are improvements. Although we achieved that scan time reduction, you can still see both the noise reduction and also spatial resolution enhancement via SwiftMR. And the volumetric analysis, I think this was a case with the NeuroQuant. And the main finding basically was that the ICC between the analysis results from the SOC scan and the SwiftMR processed accelerated scans were actually, the agreement was very high, suggesting that the reliability of brain volumetry using SwiftMR is actually is possible, or has increased. So moving on to cervical spine, as some of our previous speakers had mentioned. So in this particular case, we were able to cut the scan time by near 50%, while improving image quality, of course, and preserving diagnostic performances for myelopathy and also degenerative diseases. I know the images might be a little bit difficult to see because they're too small, but the sagittal T1, T2, your run-of-the-mill kind of spine images, and but you can kind of generally appreciate the comparable image quality despite that 47% or 48% reduction in scan time. Again, here's an axial cut, basically the same story. Moving on to L-spine. So similarly, in this case, we were able to cut down scan time by 32%, again, in a very busy tertiary hospital setting. And this is a representative T1 image showing neuroforaminal stenosis. And you can see improved image quality, again, in terms of noise and also spatial resolution, more clearly kind of depicting the lesion at the L5 and S1 level. Here's a sagittal and axial T2 images, and again, you can kind of appreciate the better visualization of the nerve roots and also the surrounding structures, despite that reduction in scan time. And you can also utilize SwiftMR for MR angiography as well. In this particular case, we attempted using SwiftMR to improve the quality of time-resolved MRA in a post-processing manner, which frequently suffer from degraded image qualities, of course. So with SwiftMR application, we were able to find that SwiftMR could contribute to better diagnostic performances in terms of both aneurysm detection and, of course, improving confidence for LVO diagnosis. And so this is a sample case from that paper, and you can see that on the right side we have the SwiftMR processed images showing better overall image quality, but also better vascular conspicuity and also sharpness. And lastly, we have a study focusing on NEMR. Of course, as you heard from our previous speakers, SwiftMR could be applied to MSK applications as well. And in this paper, we also utilized the mixed fleet of different MR scanners from major MR vendors. And we were able to show that the scan times could be reduced by 41% on average in, again, a university hospital setting, while preserving, of course, the diagnostic performance. And so this is an example case from the paper, and actually the investigators opted to utilize high level of denoising, which is another functionality of SwiftMR, allowing you to choose the amount of denoising present on the image. So when we work with your team to optimize the acquisitions and also reconstructions, we would sit with your team to make sure that the output images are to your liking, basically. The arrowheads you see on the images that you see are parallel imaging artifacts which occurred during the acceleration process, actually, and then had therefore resulted in the final image after SwiftMR processing. And I actually opted to show this because this is a good example showing you that we still need to pay very careful attention when we're accelerating your existing protocols, because SwiftMR is not designed to remove such artifacts. So when our application specialists, our CSMs, when they come in to work with your team, we pay a lot of attention to making sure that the accelerated images are still without artifacts and without any degradation, so that SwiftMR processed final output is of the diagnostic quality. So I talked a lot about some of our existing literatures focusing on validating SwiftMR in various clinical MR imaging scenarios. Next, I'll just briefly touch upon how SwiftMR could generate practical ROI upon implementation. And I think that this is a topic that both of our previous speakers had mentioned, but I'll just kind of breeze through this. So with SwiftMR, the story is quite simple, right? So we enable you to basically reduce MR scan times, which will then allow you to decrease that appointment slot times. And then this translates to actually, with, of course, after some internal workflow to optimization, of course, this will translate to more patients and therefore increasing throughput and also revenue for you. This is another case study actually from another client located in Florida, and so basically very similar story as you saw before. So after SwiftMR implementation, we were able to reduce their appointment slots down from 30 minutes to 15 minutes, which then they utilized to bring in more patients per day. And basically this 32 or 42% increase in scan volume, they saw immediate return on investment within just a few months of implementation or adoption. So in conclusion, SwiftMR basically answers the most frequently asked questions and also issues raised by the Radiological Society when it comes to adopting AI. Can it be trusted? How is it validated? And also, how does it generate actual practical ROI? And so we're always looking for clinical collaborators to continue investigating SwiftMR in various clinical settings as well. So let us know if you're interested. And we are also very much committed to being continuing to be the game changer in optimizing that upstream in radiology. And to wrap up, if you're interested in finding out more information, we're located in booth 4721. You can meet our speakers as well. And we also have 2 additional AI theater presentations, which will expand upon what was discussed in this session. So please come check it out. And we also have clinical handouts for you to view. So thank you so much for your attention.
Thank you, Dr. Yang. So we have about 5 minutes for some questions. If anyone, there's a microphone in the middle of the room if you'd like to just get up there and.
Is it on? You
Yep,
hear
there
me?
you go.
So the machine learning algorithm you guys are using is altering the actual voxels that are in each image, correct?
Oh, okay, here it is. Can you repeat the question? I'm sorry.
So the AI that you're using is altering the actual voxels, the pixels that are in the image individual, like the actual pixels in the image, correct?
Yes, correct, because we're working on the DICOM side.
Got it.
You're correct, yes.
So how do you guys handle like hallucinations with the machine learning algorithm?
Okay.
How are you able to like ensure that the algorithm isn't altering the images in a way that affects the radiologist's ability to read the scans accurately?
Yeah, that's a good question. I mean, that's, of course, a question that we get quite frequently. And it also kind of comes from experience as well, from working with different, both in research settings and also actual clinical implementation settings. We have not seen such a case where AI created something in the image or remove something out of the image, on the opposite side. But like in terms of how the technology works, I'm probably not the best one to answer this. But maybe if you can come to our booth, we have our experts ready with the answers that you're looking for, probably.
Okay.
All right.
All right. I'll have that.
Okay. Thank you so much.
Are there any other? Go ahead.
I see most of your cases are either MSK or neuro cases. Do you have any experience of using this SwiftMR in the abdominal region?
Yes, we actually have quite the number of studies, both in the body imaging, abdominal imaging side as well. We have, customers, active clients who are using SwiftMR for abdominal imaging side as well. So.
Any other questions? I actually have a question for Tim. So the validation, can you just comment on how, you said that you do the conventional image and then the SwiftMR image. How do you, do a practical validation, and how long does that take?
Yeah, so I think we ran the internal trial for probably 2 weeks. So we had a month during which time we could evaluate Swift free of charge. Hope I'm not guaranteeing something that you're not providing other people. So we had it for a month, and during at least 1 to 2 weeks of that time period, we decided that we were going to spend a little bit extra time by doing both a conventional sequence and an accelerated sequence. So we could provide that to the radiologist, and we could just kind of rotate it. It was usually 1 or 2 sequences per study, so we weren't adding a bunch of extra time to the study. But everybody was concerned. They wanted to make sure that what they were seeing after AI acceleration was equivalent to what they saw without it.
Was that essentially a consensus? Like, did you guys sit together, or did you do it independently?
Yeah, so it was pretty much done independently, but I kind of aggregated the results to make sure that there was no concerns between anybody.
Yeah. I have a question for Chris. So you had mentioned you went from 16 to 18 to your max was 32, which is really impressive. What were your hours of operation for? What have they been?
So typically it's 8 a.m. to 9 p.m.
Okay.
So that's what we did that within that space.
Okay.
Because we were seeing scans, some of our body parts were 45 minutes to 60 minutes, and some of them were a lot of them were 30, which,
Yeah.
like I said, 2 of them, we could go more, we could
Yeah.
push it. We're not ready to
Yeah.
turn that corner
So
yet.
you essentially went from 1.5 to about 2.5 scans per hour.
Right.
And you still kept your scans at every 30 minutes. And so really what you're utilizing it for more add-on cases is what I understood.
Yeah, ease of frustration for the techs, so they're staying on time. Give you that space for add-ons, so that if you did add one on, it wasn't a pain point. And we are actually toying with a 20-minute slot for those
Yeah.
45 or those 30s that we know we could kind of work on. So we're trying to work with our EMR vendor to allow us a 20-minute time slot, because it currently is structurally not
Right.
able to do that.
Operationally, right?
But yeah, so if we can get 3 in an hour, that would be probably the biggest push point right now at this current level of technology for us with Swift.
Great. Thank you. Oh, yeah, go ahead. Yeah, sure.
I would like you to answer. If you think not now, but in the future, is there a place to apply those softwares on the new machines with deep learning? Because we see Siemens and GE and all of them with deep learning. Can we apply this over those? Because I think it's the gaining will be less than on the first apply of these softwares. I think, but I'd like to.
Yeah, so you're essentially asking if our product SwiftMR can be used on top of those vendor provided case-based software. So that's a common question that we also kind of get. My answer just off the bat has to be it's not recommended, but it still works because again, like if you look at it from an operations sense, what our algorithm SwiftMR does is basically taking that DICOM image and then just reducing noise and also enhancing spatial resolution. So whatever the input is, however it was processed before, it'll still process it. But I mean, the output of that particular process, I mean, we can't really guarantee it because if you think about it, of how deep learning works, is that it has to be, the algorithm has to be trained with such images, right? But then if we go back to how when those case-based algorithms came out was basically our algorithm is not trained with those images. So therefore the output cannot really be, so we're basically relying on the generalizability of or the kind of a robustness of our algorithm instead of actual intention behind that training process. So that's kind of is my answer.